Good morning, one and all present here. Today I'm going to present a case of intra-orbital foreign body impinging into roof of maxillary sinus, a case report. No financial interest. The authors have no conflict of interest. Informed written consent was taken from the patient before the presentation. Introduction. Intraorbital foreign body injury is a common occurrence in rural population. It can present with history of injury with visible foreign body, laceration, pain, swelling, dimness, vision, etc., depending upon the mode of injury, severity, and time of presentation. Diagnosis is made based on detailed history, clinical findings, and proper imaging modalities. Case report: 38-year-old male presented to us in casualty with impacted foreign body in left orbit following accidental trauma while working at home. He sustained the injury 5 to 6 hours back. On examination, the rugged external end of the foreign body was seen in left lower orbit, which on palpation was found tightly impacted inside. Ocular motility was moderately restricted in all gazes. Mild proptosis was noted. Supero-nasal displacement of the globe with inferior conjunctival subhemorrhage and chemosis was seen. His vision was 5/60 with 28 mm mercury of IOP. Other anterior segment structures were found within normal limit. CT scan orbit was done and it showed left intraorbital foreign body impinging into roof of maxillary sinus. Here we can see the hypodense foreign body impinging into the maxillary sinus. Other routine blood investigations were within normal limit. Fundus and OCT were within normal limit. On presentation, patient was started on broad spectrum antibiotic, ceftriaxone and sulbactam after IVBD. Injection decadron once daily was given. Topical eye drop with antibiotic eye drop with steroid 1 drop 6 times daily was given with eye ointment at bedtime. Antifungal drop was given 4 times daily. Eye drop timolol was also added, and tafluconazole ODPC was given after LFT was within normal limit. And anti-inflammatory and pain killer was given twice daily. Injection diclofenac and TT was given on presentation. So as the foreign body was impinging into the roof of maxillary sinus, ENT opinion was taken, and we went forward for the surgical removal under LA by subciliary approach, and foreign body, which measures about 3 into 1.5 into 1.5 centimeter, was removed. These are the foreign bodies that was removed. On post-op day 1, his vision was 6/9 with reduction of IOP and proptosis with full ocular movement restoration. Patient was reviewed after 2 weeks with 6/6 vision with only mild conjunctival congestion and subconjunctival hemorrhage. No fresh complaint or clinical signs were noted on subsequent follow-up. Discussion. Intraorbital foreign body can be a common encounter in a clinical practice in rural areas. However, involvement with paranasal sinuses is not very common. Can occur mostly after penetrating orbital trauma. As Simha et al. In 2010 also reported a case of intraorbital foreign body involving maxillary sinus. Studies have shown that outcome of injuries is better with early intervention and prevention. However, prevention remained a priority to reduce morbidity and complications. The outcome in our case was good as patient presented on the same day of injury and prompt management was done accordingly. Conclusion: in all cases of trauma, detailed history of injury, thorough clinical examination, and appropriate imaging modalities with high suspicion index is necessary. Early diagnosis and prompt treatment should be done to salvage the eye and prevent its complications. These are my references. Thank you.